I'd like to invite up Hassan Shamsuddin, who will be presenting on behalf of co-authors from the Henry Ford Hospital, and tell us how medical centers with vascular surgery training programs are more likely to utilize autologous conduit.
Thank you for the opportunity to present this work. My name is Hassan Shamsuddin. I'm a research fellow at Henry Ford Hospital. We have no disclosures. The Society for Vascular Surgery recommends preoperative vein mapping and autologous vein conduits for infrainguinal bypass. Nevertheless, several published studies have reported up to 45% of patients undergoing infrainguinal bypass do not receive any preoperative vein mapping. The objectives of this study are to first define the rate of preoperative vein mapping and autologous vein use in infrainguinal bypass in a statewide vascular quality collaborative, and second, to examine the relationship between the presence of a vascular surgery training program and the utilization of preoperative vein mapping and autologous vein conduits for infrainguinal bypass. All patients receiving an elective infrainguinal bypass in a statewide vascular surgery registry between 2016 and 2022 were included. Patients who received an emergency bypass, those treated for non-occlusive disease, and those with a prior ipsilateral infrainguinal bypass were excluded. In the study, a vascular surgery training program was defined as any ACGME accredited vascular surgery integrated residency or fellowship. We observed a very high variation in hospital rates of preoperative vein mapping. As you can see on the graph to the right, showing vein mapping on the y-axis and the individual hospitals on the x-axis, rates of hospital preoperative vein mapping varied from 10% to 82%, with a median of 41%. A similar variation in hospital rates of autologous vein utilization was observed, ranging from 16% to 88%, with a median of only 44%. A total of 37 centers performing infrainguinal bypass were included in this study, of which a quarter were centers with a vascular surgery training program, and 28 centers were without a vascular surgery training program. Patients treated in centers with a vascular surgery training program were more likely to be of Black race and to be on dialysis, but less likely to be current smokers, have COPD, and have a prior peripheral vascular intervention. Moreover, patients treated at vascular surgery training programs were less likely to be treated for claudication and more likely to receive a bypass to a tibial target. Vascular surgery training programs achieve significantly higher operative times and higher blood loss compared to no vascular surgery training programs. When looking at rates of vein mapping, vascular surgery training programs had significantly higher rates of 58% compared to 39% for non-vascular surgery training programs. Similarly, for vein utilization, training programs had a vein utilization rate of 60%, significantly higher than that in non-vascular surgery training programs at only 45%. Interestingly, when zooming on vein utilization rates, vascular surgery training programs achieved significantly higher vein utilization rates in both single segment and spliced vein utilization. Looking at the predictors of vein mapping, female sex, COPD, prior CABG, and a prior contralateral bypass were negatively associated with preoperative vein mapping. On the other hand, diabetes mellitus, hyperlipidemia, CLTI, and the prior ipsilateral PVI were positively associated with preoperative vein mapping. Interestingly, the most important predictor of vein mapping was having a vascular surgery training program, which were more than twice as likely to perform pre-op vein mapping compared to non-vascular surgery training programs. Similarly, the most important predictor of vein utilization were also vascular surgery training programs, with an odds ratio of 1.84. Finally, we observed a strong and linear relationship between vein utilization and that of pre-op vein mapping, with a Pearson correlation constant of 0.95. So in summary, we have very low rates of vein mapping and vein utilization in a vascular surgery statewide registry. Autologous vein utilization is linearly and strongly correlated with vein mapping and infrainguinal bypass, and centers with the vascular surgery training programs perform infrainguinal bypass less frequently in claudicants and current smokers, and are more likely to utilize vein mapping and autologous conduits in infrainguinal bypass. In conclusion, Centers with training programs have higher adherence to SVS guidelines for vein mapping and utilization, yet there remains significant room for improving the utilization of pre-op vein mapping and vein conduits in this operation. Thank you, and I'm happy to take any questions.
Go ahead.
That was a great presentation. It was really nicely done. Michael Curie from Rutgers. I just have a question. Did you by chance look at volume of infrainguinal bypass by location and whether or not that correlated with use of preoperative vein mapping?
Thank you, Dr. Kerr, for your question. So we did look at the annual volume of infrainguinal bypass, and it was significantly higher for those of vascular surgery training programs. I did not include this in the presentation, but that was something we looked at.
Ravi.
Hey, Ravi Rajani again, Atlanta. Great job. Help me understand your data set a little bit better. So are 100% of the patients Blue Cross Blue Shield?
So in Michigan, there's a vascular collaborative with Blue Cross Blue Shield where medical centers are obliged to enter their data, and not all the patients were only Blue Cross Blue Shield. Gotcha. It was a combination of all the patients.
I see. Okay. Never mind then. Thank you.
Thank you, sir.
Great presentation, Young Kim, Duke University. I just wanted to confirm, you said 40% of patients are getting vein mapping before bypass. That number seems pretty low to me. Everybody at our institution gets vein mapping before bypass. I just want to hear your thoughts on how you rationalize that statistic. Thank you.
How we rationalize the 44%? Thank you for your question. We were as surprised to realize that the rate in our state is that low. We honestly don't know. Maybe some surgeons prefer doing their vein mapping in the OR, but yeah, we were as surprised.
Hi, thanks very much. Great presentation. I'm Paul Lajos from the Bronx, Montefiore Medical Center. Enjoyed it very much. Two questions for you. Number one, did you look at cephalic harvest as well? And number two, did the autologous harvesting have anything to do with being at a center where they offered endovenous harvest with cardiac surgery teams?
Thank you for your questions. First, yes, so autologous veins included all the veins, great saphenous, small saphenous, arm veins, spliced veins. So anything autologous tissue was included in this group. And second, we actually did not look at the technique of harvest. That would be an interesting thing to look at, so thank you.
Just one last question. You're saying this database is user entry. This isn't coding or some other data gathered.
No, so we have staff members that are responsible for charting those patients individually and uploading the data to them.
Do you audit this? One might surmise that an academic center might be better at data entry than a small private hospital, just to ensure that your data entry is actually equivalent.
Very interesting question. So for this collaborative, we do a yearly meeting where we discuss data entry and the percent of data entry per center. So it is well audited by the team.
Wow. Well, thank you.
Thank you very much.